picture, and but there is a different presentation. Sometimes it is slightly inverted of one feet, or sometimes it is slightly inverted of the both feet, and it's very difficult to pick in a pediatric in a neonatal screening program in a very light form. But if it is like this type of the picture, they can be picked very early and very immediately by any doctor. That is the case of the Caliphate echinovirus. As I told you, there is the some for the etiology and the association. As I told you, there is the sometimes structural and sometimes the postural. In the structural, maybe in a certain syndrome like the Edwards syndrome and a trisomy 18, in these children they can be presented with the Caliphate echinovirus as well. But if we look at the postural Caliphate echinovirus or Clubfoot, the external rotation and the final in the final trimester by the intrauterine compression. And these intrauterine compression is basically because of oligohydramnios, the very limited amount of oligohydramnios and a limited movement and a restriction of the movement, and the baby is fixed in an area, or in amniotic fluid, amniotic band syndrome, there is a fixed the baby and there is a restricted movement. So the postural event can be cause of this clubfoot. In bridge presentation, they may be presented with the clubfoot because of the baby can be born by a feet as compared to the first the head is out, and the certain other syndrome that is more than for you guys fourth year. But I told you the Ehlers-Danlos syndrome or Lewis-Diet syndrome. In these diseases, they can be presented with the clubfoot. But the one disease is common, that is the spina bifida cystica, that is the meningomyelocele. In case of meningomyelocele, there is a CNS infection, and the CNS infection, these children with the other different other presentation like urinary incontinence, stool incontinence, hydrocephalus, and other these things, they can be present with the clubfoot. And there is a one of the presentation of spina bifida cystica. And you all know that there is two type of spina bifida. One is cystica and bifida is presentation of the clubfoot. Antenatal screening. In the antenatal screening, it's a controversial. Some school of thought said there is no need to be antenatally investigate this child, but the routinely, if we go through the ultrasound and the ultrasound at the age of 20th week of gestation, you can pick this clubfoot, and antenatally you can tell to the parents or caretaker that this baby may have a clubfoot baby. So for the treatment, we can divide into two categories of treatment. The number one is the non-surgical treatment, and the number two, if there is a non-surgical treatment is in a failure stage, or there is a very severe form of the clubfoot or telepathy kind of virus, then we can be go for the surgical process. In case of non-surgical, there is basically a proper teamwork to start with the podiatrics, physiotherapist, orthopedic surgeon by the start with the manipulation and the physiotherapy of foot, externally rotated foot, physically by the physiotherapist. But if this is failure, then the second step is for the serial casting. The serial casting means there is a serial casting and there is the plaster in the lower limb for a couple of weeks, and then release it, and then again you can go for the plaster of the lower limb. If it is unilateral, then the unilateral, the one side of the foot is plastered from fingers to the knee joint, in a different position, and at least the 5 times these plaster can go, then there is a chance of there is a chance of improvement by the serial casting. In a study from the North America, they said that if the manipulation is followed by the serial casting, is the porosity method, and mostly the children can be managed by this casting and the physical therapy. The foot manipulation is usually begin within the 2 week of the birth, and it is usually the successful treatment if it is usually one-sided or not with a very severe condition. Look at this in picture of the plastic method. Look at this. This plaster is above the knee and involving the knee, then ankle joint, and up to the fingers. And it is the internally rotated. And in the first plaster, then it removed, and in the second plaster it's slightly in the straight position, but in the third plaster the foot is totally straight, and the fourth and in the fifth plaster it is in the normal position. So this is called the series of casting, the serial casting. And in case of the serial casting, the foot is start from this stage to the this stage of the proper position. And mostly children of this Clubfoot over the 4 to 6 weeks of this treatment, for 6 weeks of the treatment, the mostly children will recover without any surgical intervention. To start with the manipulation, physical manipulation and physiotherapy, and then you can go to the serial casting, and at the end of almost 4 to 6 weeks, there is usually the chance to improve this. After that, there is orthosis, and the shoe can be formed, and it is joined to each other for the maximum external rotation of the hip and the foot. So this is the final stage of the physical therapy and non-surgical treatment. But if there is a failure of this non-surgical treatment, or a child or a baby who is presented with a very severe condition, then the surgery is planned after the age of 9 months till 1 year of the age. And there is basically the surgery is for the soft tissue, and usually necessary to treat the clubfoot. However, there are the minimal surgery that may be required is sternotomy. Sternotomy is usually in the 80% of the children. It's the minor surgery with the help of the local anesthesia and just release of the Achilles tendon of Achilles. Just release of the tendon of Achilles, and it's a minor surgery, and more than 80% children who went through the surgical process is improved by this process. But only the 20% children who went to the surgical process, there is the anterior tibial tendon transfer. And this anterior tibial tendon transfer is from it's a big surgery, and the tendon is removed from the first toe, and it is attached on the third toe toward the inward traction on the foot. So this is the severe form of the surgery, but there is a very good chances to improve by this surgical process. So this is the end of the only this topic, not the lecture. इतना खुश होने की जरूरत नहीं है. This is the end of this topic, and we can go for the next topic of the Legg-Calvé-Perthes syndrome or Legg-Calvé-Perthes disease. There's a multiple name of this disease by the Perthes disease, Legg-Calvé-Perthes disease, or Legg-Perthes disease, whatever it is. But usually it is called the Legg-Calvé-Perthes syndrome. And in this syndrome, it's basically the avascular necrosis of the head of the femur. Basically, there is a socket ball movement in the femur. A socket is basically the acetabulum, and a ball is from the femur. The femur is like this, and there is the movement of the internal rotation and external rotation. There is epiphysis in the neck of the femur. At the in this from the above the epiphysis, there is the necrosis of. I will tell you in the next slide. There is basically the interruption of the blood supply to the head of the femur to close the hip joint. If there is a decreased blood supply, that means that there is a necrosis of the head, and necrosis of the head can cause the abnormal movement. And another disease, there is a slip capital femoral epiphysis. But the one thing is differentiating point between the Legg-Calvé-Perthes disease and the slip capital femoral epiphysis. वो हम पूरा पढ़ेंगे आगे. Slip capital femoral. The one thing is differentiating in these two diseases is the pain. If in case of the Legg-Calvé-Perthes disease, the pain is very severe, and that is radiating from the hip to the knee joint or in the groin area as well. And the child may be having the antalgic gait. This is the differentiating point. But in case of the slip capital femoral epiphysis, that is the painless condition. Okay. Okay. The pathophysiology of this disease is basically unknown, but the sometime because of the early closure of the ligamentum teres. But the certain risk factors of this disease is like certain inflammatory condition, hemodynamic states like altered circulation, endocrine disorder, hereditary, or the trauma. Look at this is a very important slide. It's basically the artery of the ligamentum teres, of femoris. It's basically they blocked early before the medial circumference femoral artery take over. Basically, head of the femur is initially supplying by the teres femoris artery that is converted to the ligamentum teres. But if the ligamentum teres is start constructing very early and there is a block supply before the medial circumference femoral artery take over and start supplying to the head of the femur, and this stage there is the certain collapse or deformity in the head. So the basically the necrosis of avascular necrosis and decreased blood supply of the head, they can cause the Legg-Calvé-Perthes disease. So it is called is a vascular restrictive condition of idiopathic nature, and the symptom like the femoral head disfigurement, flattening, and the collapse occur typically between the age of 10, and again it is most common in the male. Look at this picture. Sorry. Uh, sorry. Look at this picture. क्या आ रहा है भाई? क्यों आ रहा है यहाँ? In this picture, this is the ये fovea capitis, a foramen, and a ligamentum teres attaching from here, and there is a blood supply to the head, and before the medial circumference artery in the neck who start the supplying to the head, this ligamentum teres is closed and constricted, and the blood supply is restricted. Look at this. This is the growth plate. And in case of decreased supply, the above that, ideally it is in a concave phase and shape. But if there is a decreased supply, there is the irregular formation of the head. Okay, and that is the damaged and flatter femoral head, and it is more common in the male as compared to the female. Usually, the age of this disease occur between 4 to 10 years. Usually it is unilateral, but sometimes, very rarely, it may be bilaterally and intermittent limping, and usually that was during activity. Sorry, just for आदि ये देखिए ये क्यों आ रहा है? Please move this window away from the shared application. ये क्या है? इसी चलने दे, थोड़ी देर में खत्म हो जाएगा. ठीक है ठीक है ओके थैंक यू. सॉरी फॉर इंटरप्शन, मे बी देयर इज सम प्रॉब्लम. अगर ये जो बॉक्स विद द प्लीज मूव दिस, ठीक है ओके. The Legg-Calvé-Perthes disease is the most common hip disorder in the younger children and that is the 5.5 in a 100,000 children per year. ठीक है ना? And if it is not properly treated or not properly investigated in an early phase, that means maybe there is a lifetime problem. And the male to female ratio is again is high. That is more common in the male as compared to the female, and usually it is occur between the age of 5 to 14 years, but as early as it can be presented in 1.5 years of the age. Okay, yeah, okay, fine. The clinical manifestation, as I previously told you, the symptom is including the pain in the head, knee, and joint pain, and that is the exacerbated by the hip or leg movement. If there is a hip and a leg movement, then there is the chances of that is the more severe pain. So the child can be presented with a reduced range of the motion of the head. Remember that is a limping of the gait, but it is painful, very painful. The child during walking, there is the very slowly he put their foot on the ground for a couple of seconds, and immediately he moves through that. So this is the typical entalgic gait. And simultaneously, if there is the no movement in the leg for a longer period, so there is the atrophy of the thigh muscle, that is because of the disuse atrophy, and simultaneously there may be the leg discrepancy as well. So these are the different presentation of clinical manifestation of the left calf Perthes disease. So typically the disease is only seen in a one hip, but the bilateral seen only 10% of the children who diagnosed case of left calf Perthes disease. For the diagnosis, the one and the most important test is X-ray hip joint. That is that there is the flattened femoral head, and out you can confirm it by the using the bone scan or epiphysis, MRI, to check the slip capital femoral, exclude the slip capital femoral epiphysis. So but the diagnosis, you can make the diagnosis on using of x-ray hip joint. If look at this x-ray, in this x-ray, the both ball at the head of the femur is normally fixed in the socket of the acetabulum. This is the ball socket joint. You all know the hip joint is the ball socket joint, and the ball is normal. But if you look at in this X-ray, in this X-ray, the ball, head of the femur on the left side is the normal. But if we look at the right side, head of the femur is totally not the totally, but constricted or decrease formation as compared to the left side. So this is the indicating of that the head of femur is not properly formed as the, so maybe this is because of the decreased blood supply, and this decreased blood supply is because of an ultimate diagnosis of slip leg calf Perthes disease. So how we treat? Usually, it is self-limiting disease. If they can be presented with the early age, so there is the chances of picking this disease. Mhm. Yeah. Sorry, a self-limiting disease in an early age group before the age of 6 years. If it is starting before the age of 6 years, they can be improved by when the medial circumflex femoral artery is starting blood supply to that area. So there is a chances of recovery is very good. So that's why it's self-limiting disease. But the goal of treatment is to avoid the degenerative arthritis, the long-lasting pain in the hip joint. The orthopedic assessment is important, and you can take on pool the orthopedic department. As I previously told you, the younger children have a better prognosis as compared to the negative older children. The one important thing is basically removing the pressure by using the traction. The traction means to separate the femur from the pelvis and reduce the wear. And there may be use of braces, as I previously shown you a picture with a child who is like fixed, and there is a bit, this is a card as braces, and sometimes you may go for the just physiotherapy and decrease permanent damage. Okay, prognosis is usually, as I previously told you, if a child who presented this younger children of less than 6 years of age, the prognosis is best and the good, and there is a good chance of the recovery of the head of the femur, who again are typical remain in a spherical shape after the duration of the disease. But the Legg-Calvé-Perthes disease after the age of 10 years, very high risk of osteoarthritis and indulging movement or limping movement. And basically, they can be certain movement disorder and a walking disorder. Disease LCP, the Legg-Calvé-Perthes diagnosed occur after the age of 8, is better outcome result with a surgery rather than non-operative treatment. So if a child who presented after the age of 8 years, then we can go for the vascular surgery and supplying the surgery. And if the surgery is successful, then there is a decreased chance and a very good chance to recovery by after the surgery. So this is the second topic of leg of Perthes disease. Now we move over to our third topic, that is the slipped capital femoral epiphysis. As the name shows, the capital femoral epiphysis is slim. Uh, Epiphysis is what? That is the growth plate. In a growth plate, the head of the femur and the femur is attached with a growth plate. Plate होती है जिसकी वजह से दोनों attach होते हैं. And if that plate is called epiphysis, in every bone there is a epiphysis, metaphysis, and a diaphysis. You all know about it. So the epiphysis and a metaphysis is joined with the epiphyseal growth plate. This growth plate is very important for the height and the elongation of the different bones. And in case of that there's a slip of that epiphysis, there may be a different complication. The most common hip disorder, it is the most common hip disorder of the adolescent, and the upper epiphysis of femoral epiphysis is displaced, but it is remain in the acetabulum socket, while the metaphysis, the end of the femur, is moved to the anterior direction and external rotation. हेड तो अंदर रह जाता है, the femur, the neck of the femur, and that is slightly outward anterior direction and external rotation. उसमें थोड़ा सा चेंज आ जाता है, that because of this slip capital femoral epiphysis. And there is, and you know, this condition is painless condition. There is no pain or very limited pain. So approximately it's 1 to 10 per 100,000, and that Legg-Calvé-Perthes disease is 5.5 per 100,000. So almost the same. The incidence varieties, geographic location, season and year, and ethnicity. And usually the most commonly in the adolescence of 11 to 15 years of the age, and as again this is more commonly in a male as compared to the female, is 2:1 ratio. Slip capital femoral epiphysis is basically disorder can be sometimes be associated with the certain endocrinopathies like the thyroid problem, and the most important thing is the obesity. The obesity, if a child who is obese, there is the chances of this disease. The other risk factors is sometimes the family history, as I told you, the endocrine disorder. But if in case of the certain chemical reaction like the chemotherapy or radiation, they can cause the slip capital epiphysis. And a common cause is the use of the growth hormone. In case of that, there is short stature children, the treatment of short stature children, there may be chances of femoral epiphysis. In pathophysiology, basically, maybe there is a trauma of growth plate, that epiphysis or the cartilage. So, intrinsic weakness of the epiphyseal cartilage also present, and this because epiphysis gets close, and the blood supply of the epiphysis should be derived from the femoral neck. However, late in the childhood, the supply is strenuous and frequently lost after the fracture occur. So the manipulation is important. Manipulation is important of the osteonecrosis, and the blood supply is if again regained, then there is the chances of this recovery of this disease. Look at this on this picture. Okay, fine. This in this picture there is the normal epiphysis. This is the epiphysis and a growth plate, and then you look at this in this growth plate. If the growth plate is slightly slipped, this growth plate, then the head of the femur is within the acetabulum, slightly downward, but the neck or the femur is externally and outer to that acetabulum. This is not in a straight line, and that because of the slip capital femoral epiphysis. So in this situation, the gait is waddling gait. In the previous disease of Legg-Calvé-Perthes disease, the gait was antalgic. In a both gait, that is basically the limping, the variety of limping. But in antalgic means painful, the patient complaining of pain as well in that gait. But in case of waddling gait, they can walk without pain and the limping. But the motion of the hip joint is it's limited. ठीक है ना? And sometimes, very sometimes there is the pain, and up to 40% of the cases is slip capital femoral epiphysis on the both side, as because of this generalized condition of hypothyroid or maybe obesity and a pain. And then sometimes it start with the heart of the knee in 2 to 4 months, and actually basically the problem is in the hip. So sometimes it is not as early as possible you can pick it, because the patient is complaining of the problem in the knee, and you are investigating and treating the knee and checking the knee. There is a problem in the knee, but the problem is basically in a hip. So how we diagnose? As you know, the diagnosis is a combination of the clinical, suspicious, and the radiological investigation. And 50, upwards up to the 50% of sleep cover are missed or misdiagnosis on their first presentation, as the patient is starting slight pain in the knee joint, and that is basically referred from the hip. So the knee is investigated and found to be normal, and you said the knee is normal, but with the passage of the time, and there is the limping is very progressive and very in a very advanced state. So then you can think of hip, and then you can go for the X-ray of the pelvis with the anterior posterior and frog leg lateral view, and that position you can check it, and that is a picture of the melting ice cream cone type of the appearance on the hip joint. तस्वीर में इतना साफ नहीं है, not very clear in this X-ray, so we leave it this X-ray. And if we look at on this picture on the left side, this is growth is normal, but look at the right side, that is the slip of the epiphysis, and the head is slightly downward, and the neck of the femur is externally rotated on the outer side. So this is the typical picture X-ray of a disease. So how can we treat this child? To get a consultation with the orthopedic department should be in a line, and sometimes it is necessary to repair this problem. But untreated children cases can result in the serious growth abnormalities and permanent disability, leg length discrepancy, continuously with the waggling gait, and in case of the weight bearing, there is chances of the deterioration of this disease. So initially they start with this treatment with the bed rest, and again it should be regarded an orthopedic emergency, as further slippage may result in the occlusion of the blood supply and avascular necrosis. So start with the slip capital femoral epiphysis, and then it is converted to the leg calf as well. And 25% of children, if not treated early, so there is a chances of this disease. This is the cooning of in a bilateral, the screw of that is from the uh, lesser trochanter toward the head of the femur, and on both sides. This is a bilateral problem in this child. So they can be straight of this straightening of the slip capital femoral in a way where it is attaching between the head and the neck of the femur. Okay. Complication, as you know, if there is a converting to the slip capital femoral to the leg calf, but is so avascular necrosis that of the femoral head अगर totally खत्म हो जाएगा, so that is very problematic, and degenerative hip disease, and then the chronic pain and gait abnormalities. Slip capital associated with the greater risk of the arthritis in advanced age later in the life. So the last topic, but not the least, scoliosis. Scoliosis means there is a person spine is curved either to the left side or to the right side. Basically, in a three-dimensional deformity and an X-ray viewed from the rear at the spine, either in the S shape or C shape. There is a scoliosis, the lateral, there's a right or left side of the scoliosis, but sometimes the scoliosis is anterior or posterior, where that is very difficult to pick. But we look at this. This is the normal X-ray with the straight spine. But in this situation, this X-ray in the spine is scoliosis, and then it is called is S-shaped scoliosis. Look at this. This is C-shaped scoliosis on the right side, and this is on the thoracic thoracic area of its spine. But in this situation, that is the lumbar area. And both is the one. This one is on toward the right side, and this one is toward the left scoliosis. But it is involving the spine. But in this situation, they can be involved by the thoracic spine. Okay. It is congenital, and the vertebral abnormality is typically classified with the congenital, that is around 15%, but sometimes it is idiopathic, that the cause is unknown, and mostly, and that is 65%. And we subclassified into three categories: the infantile, juvenile, or adolescent. In the infantile type of that is, they can be present up to the age of 3 years, but in a juvenile from 3 years to 10 years, and after the age of 10 years or above, that is the adolescent or adult type of scoliosis. And this adolescent or adult type of scoliosis is more common in female as compared to the male. So this is maybe because of neuromuscular deformity. Neuromuscular deformity develop a secondary symptom of the elder condition like spina bifida, cerebral palsy, spinal muscle atrophy, the SMA, or sometimes the physical trauma, that is around 10%. And a lesser known cause of this scoliosis could be secondary to the cherry malformation. That is, cherry malformation is basically a presentation of the hydrocephalus, and in case of the hydrocephalus, there is chances of this disease as well. The one study from the United States, and they said there is almost 7 million people in the United States is having the scoliosis from milder variety to the very severe variety. And scoliosis is basically, you can look at this, there is a certain degree of presentation of scoliosis, starting from the 10% to the 60% of curve angle changes, and the late childhood presentation, and particularly in girls. Okay. Very simple. Clinical presentation is what the patient is either look like this. He is maintaining his head in a straight position, but spine is converting to the left side, or if it is on the right side, so they can present like this. The head should be in a straight position in the center. He maintain the head on the center, but the spine depends on the spine is moving the left side or right side. So there is the left lateral or the right lateral position. And it is and depends on the spine, so the ribs as well. If there is the thoracic involvement, then the ribs is also be in a different alignment of the rib is not in an usual position. And this side का होगा, उस side पे the ribs जो होंगी वो छोटी होती हैं as compared to the other side, and they can be handled of this abnormal movement, and sometimes they can be restricted movement of the lungs as well. You can and a total uneven hip, arm, and leg length discrepancy as well. So there is not only the abnormal shape of the upper chest and the abdomen like this, but there may be the chances of the arm and the leg discrepancy as well. A very long list of the association of this disease, and some of this disease is start with the Ehlers-Danlos, hyperflexibility in the skin and the floppy baby syndrome, Charcot-Marie-Tooth syndrome, Prader-Willi, osteogenesis imperfecta, kyphosis, cerebral palsy, SMA, SMA, muscular dystrophy, ornate cellular malformation. These are the different syndromes that they can or they may be presented with the scoliosis as well. And the school associated with the known syndromes such as Marfan and Prader-Willi is often subclassified as syndromic scoliosis. Syndromic scoliosis. Okay, fine. Basically, how we diagnosed clinical diagnosis: a child is standing in front of you with the abnormal position, with the straightening of the head, but the chest or abdomen in a lateral right or left position. But you should confirm it by using the X-ray of the spine, the epilateral, AP, and the lateral view. And sometimes you can be checked for to confirm with the MRI. But in X-ray, the important thing is taking the sorry. So curve angle. Basically, this curve angle, and if this curve angle is if it is less than 10%, the recovery chances it's very good. This is the type of taking angle, but I don't know. This orthopedic department or an X-ray department will tell you more emphasizing on that. But important thing is this: if the angle is less than 25 degree, then there is a chance of good recovery. So the therapy, the management, it is defined by the maturity and severity of the curve. The conventional options are the observation, and if this curve angle is less than 25%, the therapy is good enough and recovery is good. But that there can be with the physical therapy, occupational therapy, or sometimes there may be use of casting or bracing, and a casting for bracing for the 18 to 20 hours a day for a couple of months. But in case of the surgery, if there is a spinal fusion or the curve angle more than 45 or more on the X-ray, then you can go for the surgery to remove that curve, reduce the curve angle. In case of bracing, this is the use of bracing the whole chest, abdomen up to the thigh, and for 18 to 20 hours per day using this, and sometimes they can be improved. Uh, Risk of the undergoing surgery for the scoliosis is estimated to be the 5%, but the possible complication is basically the soft tissue or deep inflammatory process, breathing impairment, or sometimes there is the nerve injury, or if there is cutting of some artery or vein, then there is chances of the bleeding. So as early as of 5 years after surgery, and the 5% required, only the 5% children required the post-operative, again the research. Okay. Prognosis of scoliosis is basically depend when you pick and what is the curve angle. If it is less than 10%, then recovery is slightly good. But if it is more than that or more than 25% and you go through for the surgery, then the recovery is slightly less chance. And female have a greater risk of progression. And we have taken this from the different sides. And thank you very much. Any question from the student side? So I'm very koi hai. Any question? Otherwise, we go for finish this lecture if there is no question. Shabir, OS कौन conduct करा रहा है? OS at which angle will you go for the surgery? 25. Okay, fine. Kindly repeat the non-surgical. Non-surgical we divide into two: manual manipulation and the serial casting. फर्स्ट टू स्टार्ट विद द मैनुअल मैनिपुलेशन जो लेकिन जो हमने तस्वीर देखी थी इस तस्वीर में मैनुअल मैनिपुलेशन जो है वो बहुत कम होता है मैनुअल मैनिपुलेशन कैन रिड्यूस इफ इट इज slightly either it is unilateral or bilateral then you can go for the manual manipulation if there is no improvement by the manual manipulation then you go for the serial casting okay बशीर बशीर आप सुन रहे हैं बशीर शबीर हमारा कौन है मॉडरेटर usually scoliosis is not associated with pain but it can be depend of the severity and position क्योंकि देखिए वो अपने हेड को तो सेंटर में लेके आते हैं ना तो उसकी वजह से वो पोजिशनल थोड़ा सा इशू हो सकता है बट नो can a lumbar scoliosis of the 10% be corrected with the brace and the physiotherapy yes if the angle is around 10%, then you can be corrected it by braces and physiotherapy. Hmm?
अस्सलाम वालेकुम सर
वालेकुम सलाम के हो गया है मेरे ख्याल में आप बच्चे बड़ी मुश्किल से सवाल लिख रहे हैं आई थिंक इट्स फिनिश
कर दूं सर फिनिश लेक्चर फिनिश कर दूं
बच्चों
ओके सर
ओके बेटा ठीक है
थैंक यू सो मच टेक केयर